Last week we talked about the stages, the 4 stages of shock, and I'm having you focus on the fact that there are 4 stages and what they have currently and for a long period of time been referred to. Even though the Pellico book talks about 3 stages, chances are the people who are writing the NCLEX questions have not, are still thinking of it in terms of 4 stages. So that's probably what you're going to see on the NCLEX and what you will definitely see on my exams. You had hypovolemic shock and you had cardiogenic shock. The next 3 types of shock we're going to call are classified under the category of distributive shock states. And what's happening in distributive shock, it's either a loss of sympathetic tone, and what did we say that the sympathetic nervous system does to vascular tone? Causes vasoconstriction. So in some types of distributive shock, what you're going to see is a loss of sympathetic tone. So the peripheral blood vessels are not able to constrict. And remember that we talked about that as one of our compensatory mechanisms when we start to go into shock and we start to lose blood pressure. One of the things that our body does is kick in the fight or flight. We have vasoconstriction. It raises our blood pressure and improves oxygenation to the tissues. So in some types of distributive shock, you're going to lose that sympathetic tone. The blood vessels aren't going to be able to compensate by vasoconstriction, and the patient is going to have a harder time getting back to homeostasis. And then what you're also going to have in some types of distributive shock, certain situations, the presence of chemicals, and kind of should put that kind of in quotes, certain things that are circulating in the body that are causing shock, because it's increasing capillary permeability. It's damaging the blood vessels and causing them to leak fluid out into the interstitial space. What condition did we talk about in respiratory that because of the presence of chemicals was causing fluid to leak into the alveoli? ARDS. So one of the types of shocks, septic shock we're going to talk about, has the same pathophysiology as ARDS, a systemic inflammatory response that causes capillary permeability. But in this particular case, we're going to talk about all the systemic issues that can happen when that patient goes into SIRS and not just focusing on the respiratory. Yes, Allison?
Sorry, I missed what you were saying because I was trying to get this about putting something in quotes, chemicals.
Oh, the presence of chemicals in quotes. So in septic shock, the chemical would be the bacteria that's causing the infection. In anaphylactic, the chemical would be that antigen that causes the allergic reaction. Okay, so the first type of distributive shock that we're going to talk about is septic shock. So the pathophysiology is very similar to what we talked about when we talked about ARDS. We have a systemic inflammatory response. An infection gets going in the patient's body, and the systemic inflammatory response causes capillary leak, and the patient loses intravascular blood volume because the fluid is leaking into the tissues. There's 2 phases of septic shock. You will hear them referred to sometimes as warm and cold shock. The technical terms are hyperdynamic and hypodynamic. So in the hyperdynamic or warm phase of shock, that's the beginning of that systemic inflammatory response. And what usually happens when we have an inflammation or an infection going on somewhere in our body? What happens to our vital signs? They increase. So our heart rate increases, our blood pressure increases, our temperature increases, our skin becomes warm and flushed because we're trying to get rid of the infection. So in that warm phase, the initial phase of septic shock, the patient is going to be warm and flushed and pink colored, and you're going to have bounding pulses because the heart is trying to bring a lot of blood to the tissues, bring a lot of blood into the periphery so that they can diaphrese and release some of that heat. So that is the warm phase of shock. What happens, though, as that SIRS response gets more and more severe and the damage starts to be done to the capillaries by those inflammatory mediators, then we start getting capillary leak. And we start losing fluid into the interstitial space. So now our cardiac output drops, and we go into that cold or hypodynamic phase of shock. Now the patient's skin is going to be kind of cold and clammy because they're not getting good blood flow, they're not getting good cardiac output, so they're going to look like a lot of our other patients that are in shock. Cool, clammy, pale skin, mottled skin. Blood is going to start pooling in the periphery, and patients are going to develop a very common complication of septic shock, which is DIC, that we're going to talk about in a little bit. And ARDS is going to be another very common complication of a patient in septic shock, which is why if you see that patient going into septic shock and they're really severely ill, they're probably going to be on a ventilator, or a ventilator is going to be on standby, because chances are they're going to go into ARDS, because that capillary permeability is happening not only in the lungs, but also throughout the body, and why that patient, you know, looks and feels like we're describing. The etiology, the underlying causes of septic shock are frequently gram-negative bacteria like Pseudomonas and E. coli. So that patient with a urinary tract infection, which is commonly an E. coli infection, is at risk for going into sepsis and septic shock. Klebsiella is another gram-negative. Or we've got our ever-popular gram-positive staph and strep that can cause sepsis. What do you think would be the kinds of patients that would be at the highest risk for developing sepsis and going into septic shock? The elderly, the immunocompromised. Why a diabetic? So really, it's not the diabetes so much, it's the wounds. And massive decubiti can lead to septic shock, patients who have massive wounds, which is why, you know, Christopher Reeve, who probably had the best nursing care money could buy, died of septic shock from an infected decubitus. He ended up getting a decubitus. It was, you know, I'm sure they did everything in their power and money to prevent it, but he got it and he died of sepsis. So patients who have malignancies, cancers, because they're immunocompromised, or patients that are on chemo that are immunocompromised. Our treatments for septic shock are going to be based on the organism that we have identified as the causative agent. And sometimes it takes a while for those cultures to come back, sometimes 48 hours or 72 hours. So we're going to start them on a broad spectrum antibiotic, and then when we find out what the causative agent is, then we're going to get a more specific antibiotic that's going to take care of that. The vasopressor that is most commonly used for septic shock is Levophed or norepinephrine. Now, patients who have severe cases of sepsis or septic shock are at a very high risk of developing DIC. And this is kind of unique to sepsis in terms of the types of shock. And now you learned a little bit about DIC in OB, right? So what is it about? Did you learn about the two phases of DIC? Or did you just kind of learn about the end result where they're hemorrhaging? Okay. Well, there's actually two phases in DIC. It's what we would call a paradoxical thrombosis and then hemorrhage. Because in sepsis we're having pooling of blood in the extremities and we're having damage to the blood vessels, abnormal clotting occurs in the periphery because of the damage to the blood vessels and also because of the blood pooling. So in the beginning stages of DIC, they're going to have abnormal clotting. And then the body is trying to send out all these clotting factors to make sure that the clotting is taking place. And the body is also sending out natural anticoagulants to try to break down the clots. So in those early stages of DIC, you're going to see an elevated D-dimer. And remember, we talked about that. The D-dimer is evidence that there's abnormal clotting happening somewhere in the body, and the body's trying to break them down, and so you have the products of fibrinolysis, of fibrin degradation, and so they'll have an elevated D-dimer oftentimes. What eventually happens, though, is all those anticoagulants and clotting factors that the body, I'm sorry, not the anticoagulants, the clotting factors that the body is producing run out. So now the body can't clot anymore. And so then we get into that second phase, the later phase of DIC, where they have the hemorrhaging. And that's where you're going to see things like oozing of blood from IV sites, blood in the urine, hemoptysis, changes in level of consciousness because of bleeding in the brain. So in that first phase, when we're having abnormal clotting, what do you think we're going to give that patient? No, they're abnormally clotting, so what are we going to give them? Anticoagulants. So they're going to be on a heparin drip initially. And if we can stop that progression of DIC with the heparin drip, that's, then they may not go into that late stage where they start hemorrhaging. But frequently, we don't catch it until they get into that later stage and they start oozing blood. What do you think we're going to give them in that second stage when they're hemorrhaging? What's that? Coagulants like clotting factors, plasma, platelets. Because they've lost all those clotting factors. They've all been depleted with all that abnormal clotting. We've got to replace them. Just giving them vitamin K isn't going to help because they got nothing for the vitamin K to work with to start that clotting cascade. We have to actually give them the clotting factors and the plasma. So what we're going to see in DIC, and usually the most common time that we're going to see them is when they are hemorrhaging, we're going to see prolonged PT and PTT. We're going to see elevated D-dimers, decreased platelets. Let's go back to distributive shock, neurogenic shock. A loss of sympathetic tone leading to vasodilation, capillary leak, and blood pooling. And some of the causes can be spinal or general anesthesia, spinal cord injuries, traumatic brain injuries, or severe hypoglycemia can also cause, because it affects the vasomotor center of the brain, and the blood vessels dilate and they can't constrict. TBIs, traumatic brain injuries, because you've had an interruption or damage to those tracts. Same thing with spinal cord injuries. You're not getting all the sympathetic nerve impulses to the periphery. One of the signs that is very specific for neurogenic shock, different from all the other types of shock, is related to the fact that we've lost sympathetic tone. So what do you think is going to be the result of that loss of sympathetic tone? What did we say the sympathetic nervous system does to our vital signs? There's no increase in heart rate. In fact, we have a severe bradycardia with neurogenic shock. Because we know sympathetic nervous system increases the heart rate, causes vasoconstriction, and raises the blood pressure, increases the respiratory rate. What does it slow down? Sympathetic nervous system? The GI. Okay, so severe bradycardia, which makes neurogenic shock different from all the other types of shock. Because all the other types of shock, the first compensatory mechanism that we're going to see is that fight or flight increase in the heart rate. We're going to have a very profound hypotension that's going to be very difficult to manage. So you will see some patients with traumatic brain injuries and spinal cord injuries that they're not able to tolerate the head of bed being up because their blood pressure drops, because they don't have that compensatory mechanism that we all have, that when we sit up and change position, we have some vasoconstriction and that maintains our blood pressure. So what we're going to have to do for these patients is treat them with vasopressors until they can gradually, some of those impulses can be restored in some cases, and patients can tolerate changes in position and won't drop their blood pressure. Some patients with spinal cord injuries can never tolerate sitting straight up. They're always going to be in a reclining position. So to treat neurogenic shock, we're going to try to correct what the underlying cause is. So if it is because of that spinal or general anesthesia, we need to reverse that anesthesia. So patients that are in PACU, you might see with some of these signs of neurogenic shock if they're having an adverse reaction to some of the anesthesia. If they have severe hypoglycemia that's causing this, then we have to give them D50 or D10, and we have to get their blood sugar back up to normal ranges. So any questions about neurogenic? What's different about neurogenic?
Severe bradycardia.
Severe bradycardia. Okay, the last type of distributive shock is anaphylactic. And in this case, the chemical that's causing capillary leak is this antigen that's creating this severe allergic reaction in the patient. So we have a severe antigen-antibody reaction. A severe release of histamine, which causes capillary permeability, and then we have capillary leak and an increase in edema, especially in the airway, which is why that patient going into anaphylaxis has respiratory issues. Because you're having capillary leak and edema building up in and around the airway. Another thing that happens with this anaphylactic reaction is bronchospasm. So that further narrows the airway. Or hives. Has anybody ever had hives? And the rash was kind of raised, right? Because it gets edematous. Capillary leak. I know some people that get hives when they have to come and take an exam. That's not really an allergic reaction, it's an anxiety reaction. So what are some of the things that can cause anaphylaxis? Peanuts. So food allergies. Bee stings. Yeah, insect stings. Wasp or bee stings. Bites. What's that?
Eating a non-food item.
Eating a non-food item like?
I had a patient eat some soap that he thought was candy.
Okay. Anaphylaxis. So there was a chemical in that soap that caused that allergic reaction. Now you have to be very careful with patients that may have never had an allergic reaction to a bee sting, but if they get multiple stings, that can cause anaphylaxis. Yes?
They say allergies are unpredictable, so subsequent attack would be proportionally worse than the first.
Possibly. Because your body builds up more antibodies, and so when that antigen alerts the antibodies again, you'll have a more severe reaction because your body has kind of built up antibodies. So again, patients who have never had a reaction to a single bee sting, if they have multiple bee stings, or maybe the second bee sting, or the second ingestion of shellfish, maybe the first time they didn't have a reaction, or it was so mild they didn't know they were having a reaction, and then the next time their airway closes up and you know they're really in trouble. So laryngeal edema and bronchospasm and stridor are going to be very common. So when you see that patient starting to have the signs and symptoms of anaphylaxis, you better get ready to intubate them before the airway spasms and you can't intubate them. They're going to have warm, moist skin, which is going to be different from a lot of other types of shock, except when we talked about those early stages, the hyperdynamic stage of septic shock. And our treatment is going to be try to remove the causative antigen, but if they've ingested it, we just have to wait for their body to expel it, so we have to give them supportive care. So IV antihistamines, epinephrine injections, Benadryl, IV Benadryl, and make sure that you've got that respirator, that intubation tray on standby, because that patient can go into cardiac and respiratory arrest very quickly. So 3 types of distributive shock. We have septic, where the chemicals that are causing capillary leak are the infectious organism. We have neurogenic, where we've lost sympathetic tone with severe bradycardia. And then we have anaphylactic, where the chemical that's causing that capillary leak is that antigen that's causing the severe allergic reaction. The last type of shock is obstructive. Now, when we talked about cardiogenic shock, we said that the patient went into shock because the heart itself was failing as a pump, because there was something wrong with the heart. In obstructive shock, we have the heart unable to pump the blood because something external to the heart is making it too hard for the heart to pump the blood. So what are some of the things that we talked about in the respiratory unit that could cause obstructive shock? Cardiac tamponade, pulmonary embolism, tension pneumothorax, so with the mediastinal shift. So all of those things can cause obstructive shock, and our treatment for obstructive shock is going to be removing or correcting whatever the underlying problem is, whatever the causative agent is. So chest tubes if you've got a tension pneumothorax, pericardiocentesis to drain fluid that's causing the tamponade, those kinds of things. So, diagnostic tests for all types of shock. Why do we do a lactate level? What is that going to tell us?
About lactic acid.
Right. And lactic acid is the byproduct of what? Anaerobic metabolism. So the higher the lactate level, that means the more cells have converted to anaerobic metabolism. So that means that the patient is progressing further down that horrible road of decompensation, the higher the lactic acid levels. So part of our treatment and part of our assessments as we're treating that patient is if those lactic acid levels start going down, the pH should start coming up and more normalized. So we're going to see a return to homeostasis. But lactate levels are going to be elevated because of that lactic acidosis. Why BUN and creatinine? What are renal functions going to tell us? Are the kidneys working? So is it in the compensatory stage and we have a reduction in urinary output because of renal compensation, which is a good thing? Or are we farther down the road towards renal failure, and that's why our urinary output has dropped? So renal functions are going to tell us a whole lot about where that patient is in that whole process of the stages of shock. What's a chest x-ray going to tell us? Right, fluid buildup. So if we have pulmonary edema from cardiogenic shock, if we have ARDS from septic shock, if we have a pneumothorax that's causing obstructive shock, chest x-rays can tell us a lot of information. What's the echocardiogram going to tell us? How well the heart is functioning and what's wrong. So in that patient with cardiogenic shock, because of a faulty valve, that echocardiogram is going to tell us, okay, here's the problem, now we can go in and fix it. So it's going to tell us how the heart is functioning in those situations of cardiogenic or even obstructive shock. What will the abdominal ultrasound or diagnostic peritoneal lavage tell us? Right, see if there's any bleeding in the peritoneum. Because the abdominal ultrasound, we may know that the patient is going into hypovolemic shock, and we know that their H&H is dropping, we know they're bleeding somewhere, but we can't see where it is. We can't figure out where it is. They're not bleeding out externally. So an abdominal ultrasound can tell us the presence of things like, say, a liver laceration or free fluid or blood in the peritoneum. Diagnostic peritoneal lavage, where we instill saline into the peritoneum and then drain it out, should come back clear. But if we've got blood or feces where we know, oops, we've got a perforated bowel now and we're losing fluid into the peritoneum by that. So those can tell us a lot of where maybe some hidden bleeding might be when we're trying to figure out why is this patient going into hypovolemic shock. And our nursing interventions, our priorities, we need to maximize oxygen delivery. So what are some of the things that we do to help maximize oxygen delivery? And I'm not looking for rocket science here. Give me the basics. Ventimask, so delivering oxygen, suctioning, head of the bed up, mechanical ventilation. Because the underlying problem for all types of shock is what? Lack of oxygen. For whatever the reason and the cause and the underlying problem of shock, the fact is our tissues are not getting, our cells are not getting enough oxygen. That's our underlying problem. Patient positioning, we talked about head of the bed up. Now, you see in the movies, in trauma situations, they put the patient in Trendelenburg. Head of the bed down, feet up. So you might see that in those initial stages like right after the trauma, when they're trying to stabilize that patient and get any blood that might have been pooling in the extremities back to the core to help the heart have more blood to pump. But long term, why would Trendelenburg be kind of contraindicated for that patient that's in shock? Yes, Kate? It can increase intracranial pressure. It's going to depress respirations, because if you're laying there with your abdomen higher than your lungs, then all those abdominal organs are going to come pressing down on the diaphragm, and your underlying problem is still oxygenation. And if you can't take a nice deep breath and you can't oxygenate well, then we're not going to be able to stabilize you. So Trendelenburg, again, in the acute first phases of a trauma, to get that blood back into the core so that we can try to improve the blood pressure, but long-term on a patient in shock, not Trendelenburg. Why is it good to maintain a normal body temperature? Right, the body has to work hard to maintain a normal body temperature. So if the patient is too hot or too cold, it's using a lot of energy to try to normalize the body temperature. And when you're using a lot of energy, you're using a lot of oxygen and nutrients, and your cells are already crying out for oxygen and nutrients when you're in shock. So helping that patient maintain a good normal body temperature is very important. And because most of our patients are going to be on ventilators that are in shock, many of our patients, enteral and parenteral nutrition, because we have to get nutrients and to the cells that are struggling with with lack of oxygen, lack of nutrients. So that is shock, and we're going to talk just a little bit about some of the things that happen when the patient is in critical care. This can be shock patients, and many times it is shock patients, patients who have just had MIs, and the kinds of things that can happen that we have to deal with. And one of the big things that will happen in a patient that's in the ICU are endocrine imbalances. And back, I don't know if you all took certain psych courses. Did you ever hear of Seeley's General Adaptation Syndrome, stress response? Well, it's basically what we've been talking about with the fight or flight. Our bodies go through 3 stages of adaptation when trauma or severe stress occurs. We have that alarm stage, which is the fight or flight. And we talked about some of the sympathetic nervous system and how we have an increase in the heart rate, and we have vasoconstriction. But what also happens during that fight or flight is we have a release of cortisol, the glucose. Remember, we talked about how the body releases glucose to try to nourish the cells. So we have increases in cortisol and adrenaline during that fight or flight stage. So the body is just pumping away, trying to deal with all this stress. And this is what happens to a lot of patients that are in the ICU. Just the stress of being there, and all the noises and the vents and the fear of this unknown situation. So what happens is then our parasympathetic, the rest and digest, tries to counteract the effects of the fight or flight. And but the blood glucose remains elevated, the cortisol and the adrenaline levels are staying elevated because we're in a severe stress reaction when we're in the ICU. And then finally, the patient just runs out of all the resources and all the ways that it can try to counteract this whole process. And what happens is they go into the exhaustion stage. And so now all the reserves are depleted, and they're very, very highly susceptible to other types of diseases and conditions piling on top of their original problem that brought them to the ICU, which is why patients will develop so many complications. And just when you think you've fixed one problem, another one crops up, because their body has just lost its ability to counteract and fight against all these things that are coming at it in terms of bacteria and other stressors that can happen while they're when they're in the ICU. And that's why many patients will die if we can't get them out of this process and restore them back to homeostasis. So what we can have are hyper or hyposecretion of antidiuretic hormone as a result of some of these processes. So if we have too much antidiuretic hormone, what syndrome is that? SIADH, syndrome of inappropriate antidiuretic hormone. And what happens? What do we do? What happens to the body when we are in SIADH? What happens to the fluid balance? We retain fluid because we have too much antidiuretic hormone. So patients will retain fluid. Or it can happen where we have decreased secretion, and that leads to diabetes insipidus, and the patient over-diuresis, and they become very dehydrated. Patients can have thyroid imbalances. So some cancers, some infections, sepsis in particular, can alter the function of the thyroid gland, and patients can have severe hypo or hyperthyroid. So if they have severe hyperthyroid, what's going to happen to their heart rate? Very, very rapid. But they're in shock, and their heart rate is very rapid to begin with. So all of these are going to compound what's happening to these patients. The cortisol levels can cause hyperglycemia, can affect their immune response. Too much insulin can make them hypoglycemic. So the goal in the ICU now is to maintain glucose levels between 80 and 110. So that reduces organ damage. Now that's going to be really hard to do on a patient who's having the fight or flight, hypersecretion of cortisol, which is raising their blood sugar. They're on TPN, which is a very high level of high glucose, and you've probably had patients on TPN where you're checking their blood sugars every 6 hours and giving them a lot of coverage, or they even have insulin mixed in with their TPN so they don't become hyperglycemic. So they're finding more and more that controlling those glucose levels on that patient that's in the ICU is extremely important and prevents a lot of complications. Yes, Kate? Yes. Yes. What's that? In the book? Yeah, but what we're trying to get is that fasting, and because these patients, fasting is kind of not even an issue because they're not eating anyway. They're having a continuous infusion of TPN, so we just want to keep them at that as low of a glucose as we can, within those normal ranges, so that they don't have organ damage because of hyperglycemia, or conversely, go into a hypoglycemic reaction, and then again the compounding and the issues that are going to happen with that. So what we're doing with patients that are in critical care, we're starting nutritional support within the first 24 to 48 hours, and that means an NG tube feeding or a PEG tube very, very soon in this process, to help maintain nutritional status and try to balance the glucose levels. So you've got a patient on enteral nutrition. What are some of the things that we have to be looking at? This is kind of a little bit of a review of stuff that Marcia taught you way back when. Aspiration. So what do we want to have? What do we want to position them? Head of the bed up. These patients are probably on a vent as well. So you've got enteral nutrition, you've got a ventilator. We want to be at least 30 to 40 degrees head of bed. All that ventilator bundle stuff that Pat talked to us about is going to be very important. Check for residuals if we have intermittent enteral feedings. If they have parenteral nutrition, so they have a central line inserted, we need to assess for placement and assess for pneumothorax, which can be a complication of the insertion of that central line. Now, why do patients that are in the ICU, what are some of the reasons that they would have profuse diarrhea? What can be some of the causes? The antibiotic treatments, very common cause. Tube feedings can cause diarrhea. And sepsis can cause diarrhea. The whole septic process can cause that. What's going to cause constipation in that patient in the ICU? The fight or flight, that decrease in the GI motility. Very good. Immobility. Fluid deficits. So we're going to have some patients that we've got to keep giving them, suppositories and everything else to keep them moving because they're becoming constipated. We have other patients because of the antibiotics and the tube feedings. We can't stop the diarrhea, but we need to try to maintain that because the more we get imbalances in that fluid level, the harder the patient's body has to work and the less energy it has to go towards healing. Renal insufficiency is a huge issue in critical care. So we need to be monitoring what labs? BUN, creatinine, GFR, creatinine clearance. And what are some of the ways that we can prevent renal insufficiency? Give fluids. We have to maintain good fluid balance. Or PO fluids, we're not really going to, a lot of these patients are going to be on vents. We have to give them hemodynamic support, vasopressors, so that the kidneys continue to be perfused as best as possible. So when we relate that to the patient in shock, we've got a patient whose blood volume is depleted, whose red blood cells and perfusion to the target organs is deficient, and that's going to lead to, in these cases, renal insufficiency and then renal failure. So we have to, that's another one of the reasons why we give them the vasopressors, to improve perfusion to the kidneys so the kidneys don't fail. Yes? Albumin, volume expanders that are going to, anything that's going to help to expand the volume and of the blood to, again, improve perfusion to the kidneys. And then if that patient does develop acute renal failure, and many patients in ICU will do that, a temporary acute renal failure, they may have to have hemodialysis. And in many cases, it's a temporary process. They're getting dialysis while they're in that critical phase when their whole the pathology is improved, then oftentimes their renal function improves. Depending on the age of the patient and a lot of the comorbidities, some patients may end up in permanent renal failure. What are some of the complications of immobility? What are the musculoskeletal complications? Skin breakdown. What's that? About muscle atrophy? Rhabdomyolysis, where they have severe muscle deterioration, blood clots, DVTs, and so we have to put in interventions for those patients who are bedbound, who we can't get up and walk them with their ventilator, like Pat was talking about. So compression stockings, range of motion, anticoagulants to prevent blood clots. Good skin care, turning and repositioning, and good nutrition to prevent the skin breakdown. And then there's a little bit of information in the end of that chapter, the reading, that talks about some psychosocial end of life and safety issues that are really kind of self-explanatory. So we're not going to go over those in the lecture. We're going to take a 10-minute break, 15-minute break. We'll give you a chance, 15. We'll take a 15-minute break.